you all for inviting me to come tonight. I'm happy to do this. I think talking with patients is often the best way to find the answers that are, or find the questions that are important to answer within our field. And so certainly welcome any question during the presentation. A little bit about me, I'm from Cincinnati, Ohio originally. So I grew up in Cincinnati. I went to undergrad at Miami of Ohio, and then went to medical school at University of Cincinnati. I did my training, actually my intern year at Christ Hospital. So I did my first year of residency at Christ Hospital, and then moved on to Indiana University and did my radiation oncology training there. And my wife is actually a physician as well. So after training, I moved up to Chicago and worked Northwest Indiana before coming back here. And so she and I recently relocated back to Cincinnati. And so happy to be back at Christ Hospital and in Cincinnati with family. So as far as tonight goes, I got a few questions ahead of time from you all. And so I tried to structure a little bit of a talk around some of those questions to hopefully touch on that, and then potentially a little bit of how I might approach looking at a patient and deciding on what treatment, and if radiation, then what type of radiation, and how many treatments and that type of thing. That was a question that had come up. So as I said, if you have questions during, I'll try and answer. And with that, I will try and share my screen here and get going. All right. So it's kind of an outline. I think you all can see my slides now, hopefully. I'll start off by touching a little bit on prostate anatomy and imaging of the prostate, because that can be an important piece of the workup. I'll talk about staging and risk stratification, which some of you may already know about. And so some of this may be review for you. And so I apologize if I'm reviewing stuff that you already know. And then I'll talk about an overview of treatment options with a review of radiation more specifically, because that's what I do. I'm a radiation oncologist. And then I'll talk about some resources that you can search to that are publicly available on prognosis and potential side effects of treatment. And then I'll talk, there was a specific question about the role of radiation in patients with oligometastatic prostate cancer. And radiation can have a role in that setting of treatment to the prostate and or to metastatic sites. And that was one of the questions that somebody posed to me. And then I'll talk a little bit about our program at Christ and answer any questions that you all have. So I did want to, I guess when I'm in full screen, can't see the chat box as well. So I may have to exit the presentation if I have a question come across. Okay. Having a little technical difficulty. So first about prostate anatomy and imaging. So the prostate and the radiation treatment of it, the side effects that can come with treatment in this area really revolve around what's in the area. So understanding prostate anatomy is something that we can review so that you have a better idea as well. So in general, the prostate is this structure here outlined by my mouse. I believe you can see it. And so you can see that it sits right below the bladder and in front of the rectum. You have the urethra, which is the tube that goes from the bladder through the prostate and then out the penis. And so urine is carried through that structure. And so a lot of the time, men, as they age, can have increased frequency of urination caused by BPH, or benign prostatic hypertrophy. And the reason that you get increased frequency, a weak stream, and that is that growth of this structure can cause this tube to be thinner. And so urine doesn't flow through that as easily. And so that's kind of lower urinary tract symptoms like that are often one of the signs or why somebody sees a urologist to begin with. And then sometimes a PSA is checked, and incidentally, prostate cancer may be diagnosed through that route. When it comes to radiation, because we have to treat the prostate, the surrounding organs are what is at risk for side effects. And so the rectum is something that we pay a lot of attention to during treatment. And then there's another structure called the seminal vesicles that essentially provide the fluid to semen. And that is brought from the seminal vesicles through the ejaculatory duct. And involvement of the seminal vesicles is part of the staging in prostate cancer, and may impact if the seminal vesicles are involved. I'll touch a little bit on the staging and how we manage that. But if these structures, the seminal vesicles, are involved, that's a sign that the prostate cancer has gone out of the prostate and into the seminal vesicles, and that tends to be a higher risk feature in prostate cancer. And it may indicate that patients with seminal vesicle involvement may not be ideal for a type of radiation with internal seeds known as brachytherapy. And just because you can't always cover that disease to a full dose if that's involved. So I was going to just show a couple slides of what the prostate looks like by MRI. Some of you may have seen this if you've had an MRI and your physician reviewed it with you. But this is just from a PowerPoint, and this is a schematic. And in general, we think of the prostate has different zones. There's the peripheral zone and the transitional zone. In general, most prostate cancers arise in what's called the peripheral zone. So this kind of posterior structure. The transitional zone is the area around the urethra. So again, if you imagine the bladder being here, the urethra would go through the prostate and out. And the transitional zone is typically what's affected in BPH, or benign prostatic hypertrophy. And so that's very common as men age, is to get this BPH to cause the lower urinary tract symptoms that I spoke about. But that doesn't mean that you have prostate cancer. It's just a benign process that happens with time. You theoretically can have prostate cancers in this area, but most commonly it happens in the peripheral zone. And so when we look, this is a structure, an MRI looking as if you're looking from the side of a patient. So this is the front of the patient in the front of the screen. This is the back of the patient here. This is the pubic bone. If you feel kind of in your pelvic area, that bone right in the front. The bladder sits on top of the prostate here. And this is the prostate right here. These are those seminal vesicles that I showed before. And then this is the rectum behind it. And this is a penile bulb. So this is kind of the base of the penis. As far as again, this is another view, bladder, basically the same thing. This is a different view. So this view was from the side of the patient, as if, looking this way. This view is if you're looking kind of a slice through me, horizontally through, so we call it an axial slice. And in this view, you can see these are the pelvic bones on the side. The peripheral zone is this region here, and the transitional zone is more anterior. So I show this because one of the things that a lot of men have done by their primary care physician or urologist or radiation oncologist or whoever they're treating is to do a digital rectal exam. And the reason that we do digital rectal exams, or why those even are a thing, is because, as I talked about, most prostate cancers arise in the peripheral zone, which is a posterior structure. And sometimes you can feel the prostate cancer through the rectum because it's involving the posterior portion of the rectum. Nowadays, with PSA being a thing, we are catching prostate cancers before they're clinically palpable. But before PSA existed, I think it was a lot more common for men to present with a palpable nodule on their prostate. And so we're catching prostate cancer often at an earlier stage than we were previously. And as far as potential side effects of radiation, one of the big important things is what is a patient's baseline urinary function like? And some of the poor urinary function is due to an enlarged prostate. It can be. And that can alter the normal structure and anatomy and function of the essentially the bladder neck, which is an important structure that with either radiation or just at baseline, you can have enlarged prostate tissue that essentially bulges into the base of the bladder here. So this is essentially a normal bladder neck. So you can see here, this would be considered normal. If you can see here, this is a little bit of an enlarged prostate that's kind of has an obliterated bladder neck. And so somebody with this type of prostate may have more baseline urinary symptoms than somebody with the normal prostate, or sorry, yeah, somebody with the normal prostate to begin with. So this would be normal, this would be enlarged. And you can have what's called median lobe hypertrophy, which is where you get very significant growth of this area into essentially the bladder. So this is the bladder here, and this is part of the prostate essentially protruding into the bladder, and that can be factor into how we would potentially approach patients. Somebody with a very large median lobe, again, might not be an ideal candidate for brachytherapy, possibly. It can be done, and you may not have to cover that area if there's clearly no tumor there, but it's something that at least when we're looking at an image to know whether that is present or not. These are other views, so different imaging modalities. So MRI is a common one, but it's not the most common. Most commonly, patients have a transrectal ultrasound guided biopsy. And you can see here, this is the probe in the rectum. And you can see, you know, with doing these, you may not perceive it, but this is the prostate itself here, the circle that I'm outlining here. And so that's a pretty well-defined structure. Urologists and radiation oncologists are very comfortable looking at ultrasounds like this. You know, an MRI it makes it easier to see, but these are kind of the standard approach for biopsying. A CT scan here, you can see this is the prostate here on CT. This is the rectum, and these are the pelvic bones. So again, we have a lot of different imaging modalities to see prostate cancer, but seeing the actual nodule of the prostate cancer is best done on MRI. And we can sometimes see nodules on ultrasound, usually not on CT do we see nodules, but that's one kind of just so you all are aware of different ways that we can image the prostate. And so that's kind of can be helpful as we evaluate a patient. So as far as prostate cancer goes, whenever I see a patient, most of the time in other types of cancer processes, we talk about stage, and you know, patients will always ask, what's my stage? There is a staging of prostate cancer, but what's most important is the risk stratification, and risk stratification really guides how we treat patients. And so just broadly speaking, there's low risk, intermediate risk, and high risk. And those are the biggest differentiators in how we treat patients. For intermediate risk, we've subclassified that into favorable and unfavorable intermediate risk prostate cancer, because that can impact how we treat patients. And I'll talk a little bit about that as we go along. So this is a busy slide, but from NCCN, which is the National Comprehensive Cancer Network, where a lot of practitioners go to have kind of a reference for what's considered kind of a standard of care type of approach for a given scenario. And so you can see here the low, they actually have a very low, low, intermediate, and that's favorable intermediate, unfavorable intermediate, high, and very high. So there's three main factors that go into risk stratification. That's tumor stage or T stage. And that's really, is the prostate cancer palpable, or did we find it by just knowing there was an elevated PSA? The PSA itself, which the main cutoffs are less than 10, 10 to 20, and greater than 20 as low, intermediate, and high. And then the last one is the Gleason score, and that's what it looks like underneath a microscope. How closely does the prostate cancer look like normal prostate tissue? And it can look very much like prostate cancer tissue, or it can look not much like prostate tissue at all. And that's how the pathologist would grade it. And that tends to be given as a score, as you all probably know. Most commonly, it's 2 scores. The lowest that we see is typically 3+3. And then the highest would be 5+5 or Gleason 10. There's now a Gleason grouping, grade grouping, essentially 1 through 5, but that's based off of that Gleason score. So that all goes into how we would risk stratify a given patient. And that factors into how we would potentially treat that patient. And so when it comes to prostate cancer, there's a number of different treatment approaches, and depending on the clinical scenario, one may be better than another, one may be similar, and it's a discussion with the patient about which side effects they're most comfortable with and what treatment approach they're most comfortable with. And sometimes you can have low risk prostate cancer that we can surveil and not do any active treatment and wait until the time came for it to require treatment. And when a prostate cancer requires treatment under that scenario is always a tricky situation, individual kind of patient discussions on, if your PSA goes up or if your Gleason score progresses, that may be a time to consider treatment. But you often have to take into account the whole picture of a patient and what they prefer. And so the main, what I would say is kind of current standard of care treatment options are listed here. Observation, active surveillance, surgery, radiation, and hormonal therapy. I'm not a surgeon, but I work very closely with urologists, and most of the time, prior to somebody seeing me, they will have had the biopsy through a urologist and had a discussion likely about their surgical options. And then I would be seeing them potentially to discuss radiation treatment options. And surgery, just globally, there's an open approach and a robotic approach. I'd say robotic is probably becoming a lot more common nowadays. But there are still urologists that do open procedures. I won't speak much about surgery. If you have specific questions, I don't know if you have urologists that come and speak, but I can try and answer kind of the basics, but I tend to defer a lot of the surgical type questions to a surgeon just because they're the ones that perform that procedure. When it comes to radiation, if the patient is going to have radiation, it's sometimes a discussion of whether or not we add hormonal therapy to that treatment regimen. And we can do sometimes no hormonal therapy and just radiation alone. Sometimes we do radiation with a short-term hormonal therapy, and that tends to be in the unfavorable intermediate risk prostate cancer group. And then sometimes we do long-term hormonal therapy for 18 months to 3 years for patients with high-risk disease. It looks like we're getting a couple questions coming in, and I think this is a good time to potentially see what those questions are. So I'm just going to go to the chat here. Okay. Yep. And I'll be, that is one of the things that I'm going to discuss. So I will do that. So, all right. So as far as radiation goes, so again, there's other treatment options out there, but I'd say the main curative treatment approaches currently are radiation and surgery. Hormonal therapy alone is not considered curative. It can lower the PSA and keep prostate cancer under control for a period of time, but it may not eliminate the prostate cancer. All right, and so when it comes to radiation modalities, I don't know how much of you all are familiar with the NCCN patient guidelines, but if you go to the NCCN website, it has patient guides, and your physician, when they see you, if you don't have access to it or don't want to go through that, we could provide that to you. And I think I sent Jim and I sent them the early stage and advanced stage NCCN patient guidelines, and it's almost like a textbook, step-by-step workup, diagnosis, treatment, and goes through all the different treatment approaches that are out there, and it's really educational. It's a good resource if you wanted to kind of have that reference. I think that is a valuable resource for you if you wanted to, read more and know what where to go. And so I took some slides from that actually. So you can see here, this is kind of it's almost like a chapter 5 on radiation. And, they go through the different approaches, and there's 2 main types of radiation. And that's external radiation and internal radiation. And as far as external radiation goes, there's a number of different approaches. This is in no particular order. What I'd say is most common is IMRT. 3D is not really done anymore. It's really all IMRT, which is intensely modulated radiation therapy. And that's what I do most commonly. Protons are a different type of radiation. What IMRT is really high energy X-rays, whereas protons are particles. Within the center of the nucleus, there's protons and neutrons. So protons are a positively charged particle that can be rapidly accelerated and directed to the prostate or any area within the body. And the main center within the city that has protons is the University of Cincinnati. With regards to prostate cancer, there hasn't really been a suggested benefit to proton therapy for prostate cancer. It's thought potentially there might be lower risk of side effects, but that has not really been borne out in the studies that I have seen to date, at least. And so, I feel very comfortable offering IMRT as a standard. Proton therapy does not appear to be any more efficacious or really reduce any potential side effects, really. So I think that IMRT is still the standard. SBRT is stereotactic body radiation therapy, which is a way to deliver radiation with rapid dose fall off. And then we deliver higher dose per treatment. I was speaking with Jim before you all came on, and at Christ Hospital, we have a trial open currently comparing SBRT to the IMRT approach. It's a large national trial that's ongoing that will hopefully provide kind of solid evidence that SBRT is equal to or better than the conventionally performed radiation. And the benefit of SBRT is that by doing higher dose per treatment, the treatment time is less. So I'll talk a little bit about number of treatments, I think a little bit later on, I think the next slide, but brachytherapy is a different type of radiation. That's with internal radiation. And that is done typically under ultrasound guidance. So a probe is placed into the rectum and needles are introduced in the area between the scrotum and the anus into the prostate. It's not a surgery. There's no incisions. It's needles that are pierced through the skin. It's done in the operating room under anesthesia, so patients don't feel this when it's happening. And it can be done either by low dose rate brachytherapy or high dose rate brachytherapy. The high dose rate brachytherapy approach is probably the newer of the two. The low dose rate brachytherapy is kind of a tried and true, very good treatment option sometimes for certain patients. And that's a good treatment option for some patients. Nowadays, what I'd say was done most commonly in the past was that brachytherapy was done for men with low risk prostate cancer. And nowadays, men with low risk prostate cancer, we've learned that they may not need treatment, only if they have a very long life expectancy and want to have treatment, is that considered. And so this low dose rate brachytherapy as a monotherapy has probably become less commonly done than it was, say, 10 or 15 or 20 years ago. And so that is just a kind of something that's, it's just not used as commonly as it was in the past. And so this is from NCCN. This is kind of from a radiation standpoint, what are the treatment options? And the preferred regimen is this moderate hypofractionation, which I most commonly do 2.5 gray times 28 to 70 gray. There are other regimens, which is 60 gray in 3 gray fractions, so 20 treatments. So what I'd say, what most commonly at Christ Hospital, we would treat somebody with 20 to 28 fractions of radiation most commonly. The hypofractionated or SBRT approach is done in 5. So that's every other day over about a week and a half. This would be over 4 weeks to 5.5 weeks of daily treatment. And that's an improvement over what used to be the standard is probably 39 to 44 treatments or 8.5 to 9 weeks of radiation. So that's been compared, and it's been shown that these regimens are as effective as this conventionally fractionated approach. The SBRT approach, that trial that I was mentioning, is the current phase 3 trial comparing this regimen to these regimens. And so SBRT has kind of been shown in kind of single arm institutional studies to have similar outcomes and similar toxicity to these other alternatives, but they haven't been compared officially in a randomized trial for men that have been randomized to one treatment or another. And so that's an important trial that for men who fit into the inclusion criteria that I offer, enrolling them on if they're interested in doing that, because that's how we really learn the answer ultimately. So let me see. So I had a couple questions come in as I was talking about before about the SpaceOAR versus the bubble method in proton. SpaceOAR would have given me a better outcome. So I'm not sure about the bubble method for proton radiation that the person asking the question was referring to. I don't know if that's a rectal balloon, maybe. So rectal balloons are a way to essentially fix the rectum in a similar way so that you essentially know that the prostate is the same every day. The SpaceOAR or SpaceOAR, I can go back to here. It's easiest to describe probably on these sagittal images. Essentially, the SpaceOAR is a mainly gel, mostly water device that solidifies once it's injected, and it is placed under ultrasound guidance into this space right between here. And it sits there for about 6 months at the same size and provides room, as you can see here on this axial image. The prostate and the rectum, the interface of the posterior part of the prostate and the anterior wall of the rectum, they're touching each other sometimes. Sometimes men have space between there just by fat, or there's a connective tissue between that area. And so as far as the SpaceOAR provides some room in that area. Without the spacer, I feel very, a lot of the trials in radiation were done without the spacer, and the risk of rectal toxicity from that is still quite low. It's on the order of 5% or less. And so, it is a benefit to have the SpaceOAR theoretically, and it may reduce the risk of rectal bleeding, and that's kind of the main side effect that I think it helps with. But I think radiation, despite it being so close, the regimens that we have shown to be effective in prostate cancer and have a low risk of rectal toxicity have been established. And so I feel very comfortable if patients don't want a rectal SpaceOAR, then I'm very comfortable treating without it. But I do say that, most of the patients, when I talk about it, think that it's a reasonable thing to do. And I think it's a nice bell and whistle to have if patients are willing to have it done, but I don't consider it a necessity. For prostate SBRT, I would consider it a necessity just because of the dose per treatment that's given. But when we space it out more, we give a lower dose each day, and the normal rectum can repair itself. And so I feel comfortable without it if patients don't want that. But oftentimes men do. All right. And so the bubble method is the rectal balloon. So it's not necessarily specific. We can do that with photons. I typically do not use a rectal balloon. It can be uncomfortable. And disadvantages to SpaceOAR was a question. As far as disadvantages, it's an additional procedure, and it has a very, very low risk of infection. A potential risk typically is done under ultrasound guidance. And so the needle is viewed throughout the time. And sometimes there can be placement of that device into the rectal wall is a potential side effect of, it going into the wrong area. And so that's a potential risk of the treatment. That's certainly not a common thing that I see. And yes, it does eventually get absorbed by the body. So it goes and sits in its place in the same size and position for about 6 months. And then over time, it just gets absorbed because it's mostly water, and your body just resorbs it. And I had a question come in, if I have 2 lesions, are both treated at the same time? And so I guess one thing that is a common question that we get is, we know from prostate biopsies and also from the time of surgery that prostate cancer is most often multifocal. So it's rare. It's not impossible, but I'd say most of the time prostate cancer is multifocal. And so surgically, the treatment is to remove the prostate. And with radiation, we do a similar thing, and we treat the whole prostate. So we treat the whole gland at the time of doing radiation. So similar to that, we would treat the whole gland regardless. So both lesions would be incorporated. There is, I'd say, a newer approaches of focal treatments for that. And when it comes to focal treatments, I consider that's still investigational. That can be done either by, there's a number of different approaches that focal treatments are being investigated. The hard part with that is you have normal prostate tissue that can still make PSA, and so following your PSA can become somewhat problematic. But I think that that could become a treatment option in the future if it's shown to be effective and similar outcomes to that. But I think the patients that may be eligible for that type of approach might be eligible for active surveillance and monitoring. And so it's always a discussion of, what's the best option? Does that improve outcomes? Does it improve biochemical control or control the PSA? And so we'll have to see what the focal treatments show in the studies, but that's not what I'd say a standard currently. All right, so I talked about this. All right, and so these are the resources. I have a slide on the next one that the NCCN, if you go to those NCCN patient guidelines, these are the websites that they list. And so there are a number of websites out there to get education from. I do think the NCCN is a good place to start from. And you can see here a number of different other websites. I will, essentially they list the nomogram here, this MSKCC, and I'll show you that one. That's one that I sometimes use. And then there's another one from the UK that I think is also quite helpful, and one of the more recent ones that I tend to use in sometimes counseling patients. So I'm going to go ahead and show you these websites. And if you wanted to, you can search prostate predict on Google and find this. And then this is Memorial Sloan Kettering, MSKCC. You can search MSKCC prostate nomograms and find these. So I'm going to share my screen here. So I will show the prostate predict first. So I think you all can see the website here. So this is a website from the UK, and the UK has done a number of trials comparing surgery to radiation versus active surveillance. And so this particular website, there's videos on this, but it's most commonly used for men with low or favorable intermediate risk disease that are determining whether or not they need treatment. And so that's kind of the caveat to this website. Men with more advanced disease, this website is not as established. So it kind of says that when you go through this. So I'll just type in, theoretically numbers. You all can go to this website and enter in your own if after this. So I'll say 65-year-old male that has a PSA, let's say of 8, and a T stage, meaning it was found by PSA only, of 1 to T1. They had no hospital admissions within the last 2 years. They did not have testing for BRCA. Let's say they had grade group 2 disease, which is Gleason 3+4, and we have biopsy data available. Typically 12 cores are taken. And let's say for this patient, biopsy cores with any prostate cancer, let's say 4, and has the prostate cancer spread elsewhere? No. And so what this does gives you information about your prognosis. So what is my rate of overall survival? And so this would be with conservative management, meaning not doing active treatment for this patient. And this would be conservative management. If you click radical, you can see that the range of treatment benefit with regards to overall survival. Conservative would be 84% would survive at 10 years. With radical treatment, 86% would survive at 10 years. What this doesn't tell you is with the rates of it spreading elsewhere, which is a potential risk that is not shown here. Overall, men probably with this scenario would have a low risk of that, but that's something at least to keep in mind, that this does not take into account that. And so sometimes if you have a good prognosis, a long life expectancy, the treatment may be considered. But one of the question was what are the risks of potential side effects of long-term side effects from radiation? And so this website has conservative management, radical prostatectomy, and radical radiotherapy. And so you can see here that just from, this is clinical trial, this is unbiased information from trials. So I use this as a way to just show patients numbers. And I tend to use this website mostly for this information rather than the prognosis. I tend to use the Memorial Sloan Kettering nomogram for that as well. But erectile dysfunction can happen with age by doing nothing. Just the normal aging pattern can cause erectile dysfunction. With radiation, it goes from about 27% to about 40%, so 12% over what otherwise might happen with time. And it's hard to know, if you get radiation, did you get erectile dysfunction from the radiation or just with time? And it's just something that we'll never know sometimes in given patients. But again, roughly, I say if you have erectile dysfunction, or if you have erectile function, a little, around 2/3 of men will retain that, about 1/3 won't. That's kind of the number that I tend to say, or 40% and 60%. With prostatectomy, the numbers are higher, or were higher on this study. Speaking to your individual surgeon, they may have different numbers to educate you on, but at least this is from a trial that roughly 60% of men may have erectile dysfunction after surgery. And sometimes that's done, patients may be a candidate for a nerve sparing prostatectomy, which may have a lower risk than with the non-nerve sparing, but that's just something to keep in mind. One of the questions that came up was about incontinence. And so this is in the setting of upfront treatment, and with conservative management, it's uncommon, less than 1%. With radiation, the risk is maybe around 3%, which is still very low, less than 5% risk. With surgery, this trial would suggest about 20%. And this is wore one or more pads in the last 4 weeks is the number that's how they quantified this. And the question that came in was in the setting of salvage radiation. So somebody who's had their prostate removed and then they get radiation afterwards, what's the risk of incontinence with that? And there's a lot of variation in baseline urinary function that's really important that goes into the risk of that. And so what I'd say is that after you've had your prostate removed, I wait typically as long as we can to let your body regain that function, because over time and with doing Kegel exercise and other pelvic floor muscles exercises, you can see improvements in that. But I'd say when it comes to radiation, probably what you're like when you start radiation, we aren't going to make you any better. And the risk of us making you worse is probably low. You may have some acute worsening during treatment and shortly after, but most of the time I'd say the risk of that is very low. There was one randomized trial that was old in 2006. It was this SWOG 8794, and you can see it on my screen here. That was a randomized trial of adjuvant radiation versus usual care and observation. So that was in patients who had had their prostate removed. And the rate of urinary incontinence was about 6.5% if you had radiation versus 3% without. And the caveat to this is that as a prerequisite for enrolling on the trial, they could not have baseline urinary incontinence. And so if you don't have urinary incontinence when you start radiation, then you're unlikely to develop it during. That's probably around that, again, 5 to 6, here 6%. But if you do nothing with observation, you know, about 3% can. They didn't specify whether that was statistically significant in the study. With these small numbers, it's hard to say for sure whether that's significant or not. But that's one thing. And then lastly, bowel issues. That risk is here, as you can see. It's not really a common side effect with either conservative management or with surgery, but it does happen with radiation more commonly. And that's just due to the proximity of the rectum. And this is defined as bloody stools about half the time or more frequently. And so that's where I think potentially the SpaceOAR may help reduce this for certain patients. In this trial, the SpaceOAR was not used. And so it's hard to know if that was used. I would anticipate that number to be lower here, but we don't have that information on this website. So this is a useful website for you. And then another website is this Memorial Sloan Kettering website. And so this, again, there's a number of nomograms that you can use. So before radical prostatectomy, after radical prostatectomy, with salvage radiation, risk of dying, risk of high grade. And then you can also do a male life expectancy that's pretty detailed and goes into a lot of different medical problems that you might have. So that these are all different ones. The one that I most commonly use is pre-radical prostatectomy. So in the upfront setting, and they'll go through and have a disclaimer. And so we'll go through and enter similar numbers as I did before. So we'll say no hormonal therapy, no radiation yet. I think we said the person was 65, PSA was 8, primary Gleason 3, secondary was 4, T1C. I think I said 4 cores were positive and 8 were negative. So for that, you click calculate, and then it gives you the probability of cancer-specific survival. So with getting your prostate removed, the rate of prostate cancer-specific survival is 99%. So it's very high. So you're unlikely to die from prostate cancer if you have that treatment. Overall, I use this because radiation and surgery have essentially the same long-term outcomes. And so I use these numbers and essentially just say, if you get radiation, most likely these are the very similar. And the other thing that I use this website for is it also gives you extent of disease probability and what's your risk of, your likelihood of having organ confined disease. And we know that if you have extracapsular extension at the time of surgery, or seminal vesicle invasion, those are patients where you're likely to need radiation afterwards because your PSA may not go down to 0 or may start to rise after surgery. And so for patients with higher risk prostate cancer, you'll see these numbers go higher up. And so for men with high risk prostate cancer, if they're going to consider surgery, I think it's important to have an MRI potentially to make sure that these are not seen on MRI, because if they are seen on MRI, it may be likely that the patient may need radiation afterwards or have a high likelihood of needing it. And so it's always a discussion of, do we do surgery up front or do we not? And sometimes doing surgery can be done and is a good treatment approach, especially if a patient has bad urinary function, and removing the prostate would help that. But sometimes it may not be needed. So those are the kind of the two websites that I go to, at least, and some of you may find that helpful. All right, I have a couple more slides here. It's almost 8, so I think I've been talking a little bit longer than I anticipated to get through these slides, but hopefully you find these helpful. So one of the questions also that came in before I knew I was giving this was, what's the role of radiation if you have metastatic disease, prostate cancer that's spread to the lymph nodes or to the bone? And there have been a number of recent trials looking at what's the role of radiation in this setting. And I listed, the names of the trials that have been done so far. And ultimately, for men with low number of metastases, we call that oligometastatic. We would consider treatment to the prostate, actually. And that's probably the highest level of evidence that we have to treat the prostate. And we do that over 20 treatments over 4 weeks, typically. And that's been shown to have a survival benefit in a large phase 3 trial in a subset of patients that had that analyzed. And the question really came in is, would you consider treatment of a metastatic site? And there's a number of very promising phase 2 trials. Within medicine, there's phase 1, phase 2, phase 3 trials. Phase 1 is kind of safety and efficacy. Phase 1 is safety. Phase 2 is safety and efficacy. And then phase 3 is more randomized trials. So these are small randomized trials that have shown that there is a benefit potentially in either PSA control and potentially in other diseases, not necessarily just prostate radiation, but in other diseases, cancers may have a survival benefit. And so we're awaiting the results of these larger phase 3 trials. Off trial, I will consider it in men with low volume, 1 to 3 typically metastases. And that is similar to prostate SBRT. It's done over 5 or sometimes 3, or sometimes even a single fraction, but I tend to do 3 or 5. So that is something that we would offer at Christ Hospital. If you came to see me and you had that scenario, that is something that I would consider, or sometimes we'll refer those patients from either a medical oncologist or a urologist. And so that's something to at least consider, and certainly is a good question. Obviously, you're very up on current literature, because this is all kind of a hot topic currently. And so at Christ, there's a number of physicians that are involved. I believe Amber, I saw her on the call here earlier. She's our prostate navigator. I think she was on it. I don't know if she's, she may, yeah, I think she's still on. So she's very helpful in basically being a point person for all of our prostate cancer patients. And we have a multidisciplinary clinic where patients who want a potential second opinion or want to see us in a multidisciplinary fashion would have an appointment with radiation oncology, medical oncology, and urology, all in one visit. We go into a room and have a discussion of all the different treatment approaches. And so Dr. Cox is one of the urologists. He's not the only urologist that treats prostate cancer at Christ, but in the pamphlet, he made the list. Dr. Mannion is one of the main medical oncologists that treats prostate cancer at Christ Hospital. And then within radiation oncology, it really is mainly Chris, Dr. Fries, and me that would treat men with prostate cancer. And so you would meet one of Dr. Cox's colleagues or Dr. Cox, and then Dr. Mannion or one of his colleagues. And I believe I sent out a PDF of the pamphlet to Jim, and he could share that if you all wanted. But the phone number, if that were desired, is shown here. And so Amber's great and very helpful. So thank you, Amber, for what you do. And then with that, I will end it and take any questions.
Hi, this is Preston. I was wondering how much the skill of the radiation oncologist and the team that supports him influences the success of the treatment.
Yeah, I saw that question. I thank you for directing my attention back to that. I think that radiation is a very multidisciplinary. We have a team of people that we work with, and I think that overall, radiation oncology is a pretty we have certain dose metrics for different organs, like the bladder or the prostate, that we tend to want to meet before we would go forward with a given plan. And so I'd say, yes, it is an important thing to have, good therapist, a good radiation oncologist. And then we have also planners, dosimetrists that help us plan the radiation. A lot of things that you might not, patients don't see behind the scenes is that the radiation oncology department, there's the physician, and then there's also physicists that make sure that the machine quality, that it delivers what we say that it delivers. And that gets checked on a regular basis, that the output of the machine is appropriate and that everything is up to snuff. And that's actually probably done it's a mandate at every institution now. So I would say that radiation oncology is a pretty regulated specialty. And unlike other approaches, we can do the plan before we have to deliver it. So before we do the treatment, we know what to expect. When you go in for a surgery, the surgeon goes in there and he does what he does he or she does that day. And so sometimes things come up in the operating room that you don't anticipate. With radiation, we pretty much know what's going to happen before the treatment. And the therapists that treat patients every day are very good at, measure, we monitor bladder filling and rectal filling very closely. And so if somebody's bladder isn't full enough, we'll get patients off the table, make them drink more water, make sure the bladder is full enough. If they have a full rectum, we'll get them off the table, make them have a bowel movement. Often I give patients Miralax during treatment to make sure that they're regular and having emptying their rectum every day. So yes, it is an important thing to have a skilled team. Prostate cancer in general is a common cancer. And so most radiation oncologists are pretty comfortable with prostate cancer. But I do think it's important to be confident in the person that you see and who ultimately would potentially treat you. So I think that it does sometimes come down to, your comfort with your treating physician and who you trust and what you would accept as treatment.
Are there statistics available at the various institutions? Like, for example, could I go to Christ and say, what's the success rate of the treatment I'm thinking of having, whether it be the high intensity or otherwise?
We do not have that information probably readily available. As far as the numbers that I quote patients is based off of large trials for patients that have similar disease characteristics to a given patient. And so, a nomogram like the ones that I showed you would be how we would, predict the success rate of a given treatment. Because each trial that's done, the large trials, they have dose metrics that if you meet, certain coverage that you would anticipate that, if you replicate what they did on the trial, you'd expect to have similar outcomes. And that's what we do in radiation, is we have certain dose metrics that if we know the bladder dose is this and the rectal dose is this, that we anticipate a low rate of side effects. And if we have good coverage of the prostate, then we expect good tumor control. And so that's how we operate.
Thank you.
Yep. So how do outcomes of IMRT compare to LDR brachytherapy? So I would say that brachytherapy, you need to have good selection, patient selection. If patients are appropriately selected for that therapy, then the outcomes are very similar. And so LDR brachytherapy alone is really only an option for low risk prostate cancer or favorable intermediate risk. So kind of lower end of the spectrum of risk prostate cancer. And so for those patients, LDR brachytherapy and IMRT have very similar outcomes. And so sometimes the main difference in that is that it's a one-time procedure for the brachytherapy, but prior to that, you have to do a volume study. So it's a couple of visits still. The main difference is that we tend to see more acute side effects, so more irritative urinary symptoms earlier on. And so you have to have good baseline urinary function. If you have poor urinary function, we would not recommend that as a therapy. And so you really have to have good patient selection, good urinary function, lower risk prostate cancer. And if that's the case, then the outcomes are very similar between the two. Is there a contraindication if my biopsy with second opinion is one, there's a $sign, so I'll say 4+3, but my oncotype was listed as high risk. Is there a contradiction? So that's the other, so genomic testing of prostate cancer is, again, another hot topic area of how do we incorporate that into our treatment approach. And so if you have 4+3 disease, you're technically unfavorable intermediate, but if you're oncotype DX, or sometimes we often order a Decipher, which is a similar test, but gives similar information. And sometimes you can have higher risk disease, and so you can have discordant results. And so I tend to use the oncotype or Decipher score. That's not yet really incorporated. Do we change the treatment approach for that patient? I tend to use the Decipher score in men who are on the lower end and are considering whether they can observe their treatment or observe their cancer or not. If they're low or favorable intermediate risk, those are the patients who we would consider observation or active surveillance. If we do a Decipher test in those patients and they come back as high risk, then I'd be, a little cautious about recommending active surveillance. For your case where you have Gleason 4+3 disease and you have high risk disease, we don't know if doing, if you got radiation per se. For high risk prostate cancer, we give 1.5 to 2 years of hormonal therapy, whereas for unfavorable intermediate risk, we give 6 months of hormonal therapy. And so, we don't have that information yet. If for your case, if you have 4+3 disease and we would normally give you 6 months, do we get any more benefit if we give you longer hormonal therapy? And right now we don't have that information. And so I'd say current standard would be to treat you based off of your clinical information, but keep in mind that the Gleason score or the Oncotype DX or Decipher might be higher. So yeah, so there's a couple of questions about different, having pathology reviewed at different institutions, and sometimes you can have changes in Gleason scores. And so, again, I think that some of that does come down to, again, I think being confident in what the pathology is important. But I also think that taking into account, the MRI, do you have a targeted biopsy of that area? If there's uncertainty and we could observe, then potentially could consider rebiopsying. Jim asked me to make him the host, so I'll do that. How does the size of a 3+4 lesion affect size? The size of a tumor does not affect staging. It's mainly clinical. And so if we can palpate it and it takes up more than half of the prostate, or if it takes up half of the prostate, then that would be something that we would note clinically. And so it's not necessarily the size of the lesion on MRI, but what you can feel. Sometimes we can make an assessment based off of the MRI, what we would anticipate, and you can use that sometimes, but really it's the amount of the prostate that's involved, whether it's half or more than half, and then whether the seminal vesicles are involved or not in staging. So I think those are all the questions that I had. So
Could you discuss CyberKnife and how it falls into the IMRT or SBRT ratings?
Yep. So the CyberKnife is a treatment device made specifically to do SBRT. You can do fractionated approaches, but what it's really designed for is to do SBRT. And where I was at in Northwest Indiana, we had a CyberKnife. At Christ Hospital, we have what's called a TrueBeam, or the Edge, which is a Varian device that is it's a linear accelerator that delivers a very similar dose and treatment to that. The CyberKnife is really just a fancy approach to do the same thing. What it is essentially a small linear accelerator mounted onto a 360-degree arm that was modeled after essentially a car, like a robot that puts car parts together. And so it has 360 degrees of freedom, and is the treatment that we do, there's essentially the machine moves around an isocenter. So it's called an isocentric type of treatment. This one, because it can move and go in all different directions, the thought is that it can potentially offer certain advantages. Overall, I think that the machines that we have at Christ and at other places really can do very similar things nowadays. The technology for the trend in radiation in the past was to have specific machines that do certain functions. And so you might hear about the Gamma Knife or the CyberKnife, and those are two kind of radiosurgery type of treatment machines. But now the trend is kind of towards since the technology for the linear accelerator is essentially just as good, we can do the same type of treatments on that machine. And so you can kind of have one machine that can do everything.
Thank you.
Yeah, but the CyberKnife, I think that there is one in town. And so that is, it is a fancier machine, not necessarily fancier, but it's kind of unique, I guess. So, okay. Well, hopefully I didn't bore you to death. So I think that, you know, prostate cancer is can be very complex, and every patient's different, every cancer is different. And so, you know, sometimes having your specific question answered, you know, is best done by talking with your own physician. But I hope that I was able to provide you some information and potentially some of those websites that you might find helpful